Welcome to Airway Breathing Conversation, a podcast presented by the Anesthesiology Residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Miles Berger, a neuroanesthesiologist at Duke University in Durham, North Carolina, presents on postoperative delirium in older adults. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Great. So thanks again for having me. Brief mention of my conflicts of interest. I've done some private legal consulting in cases related to this topic and received material support, a loan of monitors from Massimo for a study that I won't be talking about today. And I'm a member of the ASA Committee on Geriatrics Task Force. And we are putting together a standards and practice parameters document that should be coming out next year. I've received no compensation for that, and I have no corporate or pharma funding. So brief outline, we're going to briefly talk about these perioperative neurocognitive disorders and what they are, but I'm not going to spend a ton of time on that since I know you guys have already had several Grand Rounds talks on that. Second, we're going to talk about brain anesthetic resistance and delirium, or how the brain responds to anesthetics, at least as measured by EEG, and what insights that can give us about delirium and other brain disorders. And then third, we're going to talk about blood-brain barrier dysfunction in postoperative delirium, and then I'd be happy to take questions afterwards. So just a brief background so we're all on the same page. So the field of POCD, or post-op cognitive dysfunction in delirium, had sort of started to resemble the biblical Tower of Babel in the 2000 to 2015 or so era. And I say that because there were many studies on the topic. There was no shortage of people studying it, but they were all kind of defining it in different ways, which made it really hard to compare results from one study to another. And so a group of people got together, and I was fortunate to be part of the group that put together these recommendations for how we should all think about these disorders and define them so we could kind of be on the same page using a common language, as it were. So the idea is that after anesthesia and surgery, you can have delirium, postoperative delirium, and that usually occurs within days after surgery. And then you can also have what's called delayed neurocognitive recovery, which is a fancy way of saying confusion or memory loss or cognitive dysfunction within days to 1 month after surgery. Once it's been 1 month after surgery, up until 12 months, so between 1 month and a year after surgery, then we're referring to this as mild or major neurocognitive disorder, postoperative, or mild or major postoperative neurocognitive disorder. And the criteria for that are the same as the general criteria in the DSM-5, the Diagnostic and Statistical Manual for Mental Disorders, that's used in psychiatry and to some extent in neurology as well, which basically says, a mild neurocognitive disorder is about a 1 to 2 standard deviation decline compared to population norms in cognitive testing or cognitive function, and a subjective cognitive complaint. And that's a major difference between the POCD literature and this newer literature, is now we're saying it actually has to affect the person in a detrimental way. They have to, have a subjective complaint. And then for major NCD, postoperative, again, between 1 month and 1 year after surgery, the person has to have a more than 2 standard deviation decline on testing, and they have to have a subjective complaint, and they also have to have an impairment in an instrumental activity of daily living or regular activity daily living. And that's basically the same criteria the DSM has for major NCD outside of perioperative, or postoperative setting. And it's in the DSM, that's effectively the equivalent of dementia. Longer term, then after 1 year, the feeling of this group was it's really hard to attribute any kind of cognitive dysfunction to anesthesia and surgery if it's occurring more than a year afterwards, because there's so many other things that could affect that. So at that point, we don't use the modifier postoperative anymore. We would just consider this NCD, neurocognitive disorder, mild or major. And that would just follow those same criteria. that the DSM-5 includes. And there's some references there for the recommendations and nomenclature document that was published simultaneously in a number of journals listed there back in 2018. Again, with the goal of getting us all on the same page and how we talk about these disorders. So my group is very interested in studying the mechanisms of these disorders and trying to understand what's really going on with them. And as Dr. Hedlund and I were discussing before this meeting, I think a real challenge in this field is that we all kind of know these things exist. I think probably all of us have interacted with a patient at some point in our training or as attendings who just seem confused after surgery, or have heard complaints of people who said they couldn't remember things as well after surgery, et cetera. That idea is out there in the community, but we don't yet have a drug that we can give to treat it. There's no FDA-approved drug in the US for treating delirium or postoperative neurocognitive dysfunction. There is no drug that there's really level 1 evidence for preventing or treating these disorders. I think the closest one might be dexmedetomidine. And even for that, there's very mixed evidence. There's some randomized controlled trials that show benefit in reducing delirium. There's some that show no effect. So it's really hard to know. So the approach my group has taken to this problem is to say basically, well, the reason we don't have any treatments is we don't understand what these disorders are at a biological or neurobiological level. Either we don't really understand them at a molecular cellular level, nor do we understand them at a brain systems level. And so that's really our goal, is to understand what's going on in the brains of patients with these disorders. Now, a lot of things have been implicated, and this is from a review article we wrote 5 years ago now. And so starting at about the noon or 12 o'clock position up here, you can see this description of neurofibrillary tangles and amyloid beta monomers, and there's a whole large literature showing that anesthetic drugs and surgical stress can modulate these processes. And there's been a theory for a while that anesthetics and surgery might do something to Alzheimer's disease risk. I'm not going to talk about that today, but just to mention that is an idea that's out there. We know there's changes in cerebral oximetry that can occur during surgery, and that could obviously affect brain function. There's a whole literature on anesthetic dosage and whether excessive anesthetic dose affects brain function. We know that a lot of physiologic derangements happen during surgery, particularly during major cardiac or major cardiovascular or neurovascular surgery, including changes in mean arterial pressure, glucose, arterial oxygen concentration, temperature, hemoglobin levels, et cetera. All those things are going to impact the brain. And then we know there's a profound inflammatory response to surgery, and there's an active process that shuts that off days after the surgery, this resolving or resolution of inflammation process. And that clearly plays a role in these disorders, at least in animal models. Then we know there's vascular mechanisms. You can have plaque ruptures, you can have emboli, especially in vascular or cardiac surgery. And then I'll talk later today about some of our work on blood-brain barrier dysfunction. So for anybody who likes complexity, this is a great thing to work on because there's a lot going on, and there's not a single mechanism probably that's the mechanism for all of this. So how do we study this? Well, you can think about the brain in terms of space and time. So on this graph, this XY graph, we've got space on the x-axis, we've got time on the y-axis. And this is what we basically have for human neuroscience. I haven't included every technique, but you can think about techniques in terms of their spatial resolution of the brain, and then in terms of what time period they measure things over. So for example, to do a cognitive test battery might take an hour. So that's down here. It might take minutes to hours, let's say, but it's really off the spatial scale because you're measuring a function of the brain as an output. You're not actually measuring something within the brain. On the other hand, you can measure CSF biomarkers, and we'll talk more today about some of that. You can measure things down to the level of angstroms, 10 to the minus 10th meters, if you're looking at the structure of an individual protein. However, if you're doing that in the CSF is sort of like a hemoglobin A1C for the brain, if you want to think of it that way. It's an integrated average of everything that's happening in the interstitial space of the brain at the actual synapses where the actual information transfer we think is happening in the brain. It's an average of all of that over hours to days. So it's not giving you information on the time scale that the neurons are spiking at. On the other hand, We have EEG, which has a resolution of maybe centimeters if you have a really good dense cap that has 32 channels, and I'll talk about some of that data today. EEG is very, very temporally sensitive. It's probably the best temporally sensitive measurement we have. It can measure things down to a millisecond time frame. We measure things in 256 hertz, which means we're making 256 electrical measurements per second, or 1 every 4 milliseconds. So that's close to the time scale on which an individual neuron spikes. However, the spatial resolution is quite poor because, again, it's not really seeing what individual parts of the brain are doing. It's just a rough sort of scalp measurement of, what the frontal part of the brain is doing versus posterior parts, et cetera. So in this first part of the talk, I'm going to tell you about some of the work we've been doing using both EEG and cognitive and delirium testing to study these disorders. One other point I would just like to make is that there is no perfect technique in human cognitive neuroscience or human neuroscience. A perfect technique would measure things at all of these time scales, at all of these spatial scales. So it would take up this entire graph, if you will. But that, as you can see, that just doesn't exist. There's different techniques that are better for space or better for time, and there's trade-offs between all of them. Our general approach is to combine techniques so we can gain insights that you probably couldn't obtain from any one technique on its own. And we'll go into that now. So just a little background to this. So as all of you know, the CNS, the central nervous system, is the target organ for all of our sedative and anesthetic drugs. That's the brain right there. Yet the CNS, the brain, is one of the few, if not the only organ systems not evaluated in a routine pre-op evaluation. There's nothing in the ASA guidelines for preoperative evaluation that says anything about what you should do to evaluate brain function or cognitive function, at least not in the current guidelines. And further, intraoperative CNS monitoring or brain monitoring is not standard of care per the ASA. Dr. Hedlund was telling me he estimates maybe 5% or so of cases at y'all's institution use intraoperative EEG monitoring, and that's pretty standard at many American institutions as well. In my own institution, we do a bit more than that. Maybe a third of cases get EEG monitoring, but still, it's not that common. So despite the fact that the brain is the target organ of all of our drugs, it's one of the few, if not the only organ we don't routinely evaluate, and we don't evaluate during surgery either. And that's irony. That's pretty ironic to me. So it's become clear to us in some of the work that we've published that patients' brains don't really respond the same way to anesthetic drugs. And there's been a lot of work by Emery Brown, Patrick Purdon, many other colleagues showing the brain's response to different anesthetics and showing that there's distinct EEG responses to different types of anesthetics, et cetera. This is work we published now 6 years ago, in which we found there's also significant variance across patients' brains and how they respond to anesthetics, even for the same anesthetic. And so this is 8 to 12 hertz or 8 to 12 waves per second oscillations in the EEG or electrical brain waves measured on the scalp across patients' brains during anesthesia. And this is a heat map. So this is like the nose of the patient. You'll have to pardon the artistry. And these are essentially the patient's ears. Whoops, excuse me. And this is the back of the patient's head towards the bottom. And what you can see is a heat map. So bluer colors mean less power or less signal intensity. And the orange colors indicate, or hotter colors indicate more intensity. And so these are two patients, and you can see there's a quite different brain response to the same anesthetic. And so to really go into this, I need to explain to you guys how to read these spectrogram graphs, which look like this, which look a little psychedelic at first. So let me, to explain these, let me start with a stereo equalizer and put it on its side. So if any of you guys are old enough like me to remember when we had these manual stereo equalizers with these knobs you could push up and down, right? They used to have knobs at 20 and 40 hertz and knobs at 17 or 20,000 hertz up here. And these are the bass frequencies, like a bass drum or a bassoon or something like that. And these are the higher pitch frequencies, like that of a soprano's voice or a flute or something like that. And that's exactly what this graph is showing in a sense. It's got frequency on the y-axis, only the frequency is not the frequency of sound. It's the frequency of the electrical waves that are measured at the scalp that come from the brain. the frequency of these EEG waves. And then time is usually represented on the x-axis of these graphs. And then the heat map colors are used to indicate intensity. So here you can see there's a lot of intensity at 0 to 2 hertz. There's a little bit of intensity around 10 hertz. And then there's a big drop off and much less intensity above 20 hertz. So that would be like if you cranked up, the bass a lot, maybe cranked up the high bass, low mid-range a lot, and then turned everything off on your stereo, so to speak. And that's the characteristic brain response pattern in response to inhaled anesthetics and to propofol, essentially. And so this was work published now by Patrick Purton and Emery Brown and colleagues now 8 years ago, where they did that spectrogram that I'm telling you about, but they reduced each individual patient to one line, one vertical slice, okay? And then they combined these slices from a whole bunch of different patients of different ages. So you could see how the brain anesthetic response pattern changed as a function of age. And what you see is that there's a lot of delta power in all ages. Here, let me get my mouse down here. So you can see there's delta power, there's 0 to 2 hertz, across the age spectrum. But the alpha power, the 10 hertz oscillation, kind of disappears above age 65. Now, this graph just shows you the averages. It doesn't show you the variance in the population. But when I saw this, I was very interested in the fact that, patients over 65 are those who have the highest incidence of delirium. So I wondered, well, was low alpha power maybe a predictor of delirium or a predictor of cognitive dysfunction? And next, I'll tell you about some of the work we did to investigate that question. So for this work, I teamed up with Marty Waldorf, who's a cognitive neuroscientist here at Duke, and Charlie Giattino, who was a graduate student in his lab at that point. And we did 32-channel EEG recordings. So we had a cap that goes across the whole scalp. It looks a little bit like a old cosmonaut helmet from the space era in the 50s and 60s, or like an old leather football helmet. And then we had BIS EEG recordings with the frontal BIS electrode system in about 35 patients. And that's the reference down there for anyone who's interested. This is what our patient cohort looked like for the 32-channel cases. So we had about 15 of those. They were patients about age 70, half male, half female, pretty long, over 4-hour surgeries, and they were all ASA3 patients. And this is a top-down view of the cap that the patients were wearing. And so we looked especially at these 6 frontal electrodes. And the reason we looked at those is that John Mitchenfelder and others back to the 1970s had shown that there's this phenomenon of what they call anteriorization of alpha power under anesthesia. And let me explain what that means. If you do a full cap EEG recording on somebody, normally you don't see much alpha power. If you tell the person to close their eyes, then you see a lot of alpha power over the posterior areas of the back of the head, over the occipital cortex. And these alpha waves, or 8 to 12 hertz oscillations, are thought to represent sort of quiescent cerebral cortex, or kind of offline cortex. And it's thought that the reason why these oscillations appear when somebody closes their eyes is that then their primary visual cortex is cut off from the information stream coming from the retina and coming down the optic nerve into the visual cortex and the occipital lobe. What's interesting is that under anesthesia, that occipital alpha power shifts to the front of the head in a very pronounced way. And then you see this frontal alpha power, which you never see normally when somebody's awake. And so what we did is we looked at this alpha power over the frontal areas of the brain or skull, and we just graphed this compared to the preoperative cognitive index. So this is effectively a Z-score, if you will, where a negative score means below normal and a positive score means above normal. And so you can see there's a range of patients. It's a bell curve, as you'd expect, for cognitive function. Some people are a lot lower in cognitive function. Some people are much higher, like this individual out here. What was interesting is there was a pretty reasonably good correlation, at least for human subjects data, between the magnitude of this alpha oscillation, or these 8 to 12 hertz waves in the front area of the skull, under anesthesia and pre-op cognitive index. And so we wanted to investigate this further. We had 35 patients who had BIS EEG recordings. So again, that's a frontal EEG strip that measures the same alpha. Well, we used the index is calculated from the raw signal. Here, we didn't use the index values. We used the raw signal to extract the alpha power. So we're looking at that same 8 to 12 hertz alpha power, but measured by the BIS electrodes across the forehead. And again, you see this very nice, reasonably tight correlation between pre-op cognitive function and alpha power. So people with the best pre-op cognitive function up here tended to have really robust alpha power in response to anesthesia over the frontal areas of the brain. And in contrast, people who had really poor preoperative cognitive function down here tended to have much lower intraoperative alpha power. So this suggested to us that we could make an inference just from looking at how the brain responded to EEG in the OR. We could make an inference about what that person's cognitive function is likely to be like. Now, you can see here, it's not a perfect correlation by any means, and there's still a fair amount of spread along the line, although I think you can clearly see the data sort of fits the line. It's not just a random distribution of data, which indicates, if somebody has pretty low alpha power, you can't say for sure, but the odds are they have below average cognitive function before surgery. And those two pictures I showed you before at the beginning of this part of the talk, those were actually the alpha power heat maps of the two patients with the most extremely poor and extremely good preoperative cognitive function. So the patient with the best preoperative cognitive function, he or she had this very intense alpha power over the frontal parts of the brain. That's exactly what you normally see in response to anesthetics and what Mitch and Felder published on approximately half a century ago now, back in the 1970s. And on the other hand, the person with the worst preoperative cognitive function, you see this cool blue map all over the skull, and you don't really see, you almost see no alpha interiorization over the frontal parts of the brain, maybe a little bit right here, but it's still pretty cool colors and nothing like the intensity that you see here in the person with the best pre-op cognitive function. Now, this isn't just something that we found. This has been replicated independently by Susanna Koch and colleagues in Europe in the BioCog study. And they did something very similar. They grouped patients into those who had normal baseline cognition and then those who had impaired baseline cognition with a cognitive test battery. And I think you can see there's a lot more alpha power, a lot more red heat in this 10 hertz range in the people with normal cognition as compared to those with abnormal or below normal cognition. And other investigators have gone on to then ask the question, well, is this associated with delirium? And people have found to some extent that it is. This is work by Gutierrez et al. Now 4 years ago, showing that the relative alpha power is much higher in people who didn't develop delirium versus those who either had delirium or subsyndromal delirium. So this is post-op delirium or post-op subsyndromal delirium. And you can see that's a good bit lower than this, and that was significant. And in fact, if they compared the sensitivity and specificity of intraoperative alpha power for postoperative delirium, you can see on this ROC curve, it's a reasonably good fit here. The further you are up and to the left, the better your data is fitting or predicting the outcome. And the interesting thing is, if you compare this to MoCA or Montreal cognitive scores, it's actually better than MoCA scores at predicting delirium risk, and it's better than age. So this suggested that you could just look at how the person's brain is responding to anesthesia in the OR if you have an EEG monitor, and that actually tells you more about their delirium risk than either how old they are or how they did on a MoCA cognitive screening test. Now, some of you may be wondering, well, what's he talking about alpha power about? Because the papers in the literature often talk about burst suppression and what's the relationship between burst suppression and alpha power. So there's definitely a relationship between the two of them. And this is work from Ray Shao, who was at this time at MGH working with Patrick Purdon and Emery and colleagues there. And what they showed was that the probability of a patient entering burst suppression or an intermittent flatlining of the EEG signal, it would be sort of like an intermittent asystole or asystolic pattern on an EKG. They saw that there was a very clear inverse relationship between burst suppression probability and alpha power. So the people with high alpha power had almost a 0% probability of going into burst suppression. And vice versa, the people at highest burst suppression probability had very low alpha power, or vice versa. People with low alpha power had a lot of burst suppression and a lot of burst suppression probability. So if you're wondering, what does this have to do with the burst suppression literature? Every time I say low alpha power, you can basically think of that as meaning more burst suppression. And every time I say high alpha power, you can think of that as meaning a lot less burst suppression. And in that way, you can think about these two literatures on burst suppression and alpha power as two different sides of a coin, effectively. But there's a problem with all of this. And some of you may have noticed this in a graph I showed before, and that is that anesthetics also affect the EEG patterns. And as you know, we don't usually give just one anesthetic drug. It's pretty rare that we'll do a case with just isoflurane. So this is the spectrum of a patient that was in one of our studies. And this patient was getting, I believe, a propofol Tiva, total intravenous anesthesia. And you can see here's the alpha power, here's the delta power. It looks pretty much like what I showed you, a typical spectrogram looks like in response to propofol. However, then somebody gave ketamine right here where this arrow is. Suddenly you see the alpha oscillation disappear initially, and then when it comes back, you can kind of see it goes to a slightly higher power, And the other thing you can see is that the overall power spectrum shifts to a bit higher frequencies. You wind up having this light blue or turquoise power up to 30 hertz here in a much higher intensity than you ever did before the ketamine. So you can imagine if you were trying to infer what somebody's cognitive function was by looking at alpha power, you would get a misleading interpretation if you looked right here, unless you could take the ketamine into consideration. And the same thing is also true about just the level of propofol or the level of inhaled anesthetic you're giving. If you give enough, as I'm sure all of you know, if you give enough propofol or enough inhaled anesthetic, you can put somebody into burst suppression and take their alpha power down to zero. And we do that sometimes in neuroanesthesia, for neurovascular cases where they're cross-clamping an artery in the brain for neuroprotection. So it made me think that we had to think about the EEG more in context of the anesthetic dosage, not just as a function of the patient's brain. And this got me thinking about this question I had wondered about ever since residency here at Duke, which is, what does it mean if somebody is getting a low MAC fraction, but yet they have a low BIS index? It sounds like you guys don't use a lot of BIS, but hopefully you're familiar with it, at least in basic terms. So the BIS is this frontal EEG monitor, and it gives you this processed index number. It's a non-dimensional, unitless index that goes from 0 to 100, where the company says that you should aim for 40 to 60 to keep somebody anesthetized and amnestic. And usually that's about what happens. If you give a reasonable anesthetic dose, like 0.7 MAC, let's say, 0.8 MAC, usually you get a BIS in about the 50s, right? That's pretty much normal. But there were patients I saw as a resident who we would give almost no anesthetic to, like 0.2, 0.3% isoflurane or 0.2, 0.3% MAC, regardless of which agent. And yet their BIS would be like 10 sometimes or 20. And I always wondered about this ever since I was a resident. And somebody actually asked the chief of neuroanesthesia when I was a resident, hey, what does this mean? I've got this patient. We're giving almost no gas, and yet their BIS is 10 to 20. Does this mean they had a stroke? Should we get a stat head CT, et cetera? And the chief of neuroanesthesia at that time just said, no, well, we see this sometimes. Don't worry about it. Keep going. You don't need a scan. And that was correct, but it seemed to me that it couldn't be the whole story, because it just seemed to me that this was such an unusual phenotype that it had to mean there was something wrong with the brain. I just couldn't accept that some people would just have this response and it meant nothing. And so I wondered for a long time about this and what was going on with these patients. And I made this chart one day in my office, and I thought, well, you can either have a low BIS, a normal BIS, or a high BIS, and you could either be getting a low normal or high anesthetic dose. And then I thought about what each of these mean, and I told you about the normal one. It's pretty clear what this means. If you're giving too much gas and your BIS is low, that makes sense. You just probably shouldn't be giving that much gas unless you're trying to burst suppress the patient. And on the other hand, if you're giving a very low dose and the BIS is high, that's a simple enough interpretation. You ought to give more gas so the patient's fully anesthetized, right? But it was this quadrant that we didn't really know what that meant. And so I kept thinking we got to figure out a way to quantify this quadrant and to study this more. And we needed really an equation that could look at these two variables together. So our chair who recruited me to Duke when I was a resident was Dr. Mark Newman, who's now in Kentucky. Dr. Newman's a great man and was in the military for many years, so he was fond of acronyms. That's a big thing in the U.S. military. And so we thought we needed an acronym. So we called it the DARS, or the Duke Anesthesia Resistance Scale. It's not that I'm trying to be so self-promotional about Duke. It's just that if you don't have the D on there, you have ARS, and that might be pronounced ARS. And we didn't think that was a good way to portray our index. So in any case, the DARS we set up equals the mean BIS score divided by 2.5 minus the mean end tidal AA MAC fraction. So it's a simple, relatively simple equation. There's no calculus, there's no exponents. It's just addition, subtraction, and division here. But let me explain where we came up with this from. We did a study, which I'll tell you about a little bit later in this talk, where we analyzed the anesthetic records of 17,000 people that got general anesthesia at Duke over a 2-year time frame. Okay. And out of those 17,000 cases, we calculated what was the mean end tidal age-adjusted MAC fraction of all the patients. And we got what basically looked like a bell curve distribution. Most people got 0.7 or 0.9 MAC or so, maybe 1 MAC, but there were outliers on both the low and the high end. And the highest outlier, the patient who got the highest age-adjusted end tidal MAC fraction, on average, over the whole case, got 2.5 MAC. That is a whopping dose of anesthetic, as I'm sure you all know. If you were using sevoflurane, that would mean you had 5% end tidal sevoflurane for the entire case. So we reasoned, we couldn't believe it when we saw that. And then I started to understand when I read about the case. Somebody used an LMA. It was a highly stimulating and highly painful case. They didn't give very much opioid. So they effectively used the gas as a full anesthetic rather than a balanced anesthetic. There was no paralytic. There was very little opioid. So it was more of a pure or unitary anesthetic. So we reasoned that we would find it hard to believe anybody would ever give more than 2.5 end tidal age-adjusted MAC during a case on average. And if you guys are aware of that, of anybody doing that, please let me know, because I can't imagine somebody doing that. So the denominator then really means the maximum MAC fraction that you could ever give in clinical practice, or that we think would ever be given in clinical practice, minus what your actual patient got. So this would be like, if you want an analogy, it'd be like measuring the difference between the tallest human being in the world and a more normal fellow like me who's 5'9". It's that difference between the maximum possible and the actual patient or the actual individual. And then we've got the mean BIS score over the case in the numerator. And I'll show you why we set up the equation this way. So let's go back to that matrix I just showed you a second ago. So this equation has some interesting properties. So if you take somebody who's getting a normal dose of anesthesia and they have a normal BIS, let's say 50, their DARS score comes out to about 25 to 30, okay, 27.8 in this scenario. And on the other hand, if you give a huge anesthetic dose, and yet the BIS is still really high, you get a very high DARS score, 70. So this is basically telling you that person's brain is very resistant to anesthesia. In other words, their brain is resisting having the BIS number pushed down. Their brain is resisting going into a deeply suppressed state, despite a very high dose of anesthetic. The brain is resistant to anesthesia. On the other hand, if you have somebody like the quadrant I was concerned about before, where you're giving very little gas, and yet you have a very low BIS number, let's say 20 or 30, you get these very low DARS score numbers, like 10, 13, something like that. And so we thought of this as that means that brain is very poorly resistant to anesthetics. Or in other words, if you think about what's happening to the brain in terms of like equilibrium, like in chemistry, right? You're using the anesthetic to shift the brain's equilibrium to a different activity state, right? And here, you're able to shift it to this low activity state or high suppression state with very little gas. It means the brain is not very resistant to the anesthetic effects or the neurophysiologic effects of the anesthetic. The brain is not resistant to those. And so we wanted to know, with this equation in hand, what happens to these patients who in this general part of the this whole matrix generally, I would say, are poorly resistant or have low resistance to anesthetics. And for this, we teamed up with two groups of folks, Doctors Legou and McDonald here at Duke, who run the POSH clinic here, which is a geriatrics, perioperative screening and follow-up clinic, and my friend and colleague, Dr. Stacy Diner, who was at Mount Sinai at this time and then moved to Dartmouth. And This is Mary Cooter Wright, who's an outstanding statistician with our group, who's done the analysis for this, and I've had the good fortune to work with for probably almost a decade now. What Mary found is here, if you compare the patients with delirium and without, there's no difference in delirium rates by site, the age, the gender, all this stuff is not really different, and that's exactly what you'd expect. But if we look at people that had a low DARS score, so a DARS below 30, so again, that suggests their brain is not very resistant to anesthetics, that they're going into a very low BIS number despite not receiving much gas. Those people have a much higher delirium incidence here on the y-axis than those who had a high DARS or a DARS above 28. And that was highly significant with an odds ratio of about 4 in that paper. And again, there's the DARS equation if you're interested. And we then wanted to do some multivariable models to adjust for various other things. We did that, and no matter what you adjusted for in the model, you can see here the odds ratio for delirium from the DARS ranges from about 3.5 to 4. So it's a significant risk for delirium, even in multivariable adjusted analyses, where you control for which site the patient was at, risk factors, other medications they were on, et cetera. It doesn't really matter. And it didn't matter whether you use the optimum DARS cutoff or the upper bound of the DARS cutoff range that we used. Either way, you had about a 3 to 4-fold increased risk of delirium if you had a low DARS. Now, I should mention, we're not the only people to observe something like this. This is an equation that was written by another colleague, Brad Fritz, at Washington University in St. Louis from a paper they had several years ago. And this is a much more complicated equation. Brad is much more mathematically talented than I am, I think. And you can see there's all these different terms, multivariate terms in the exponent in the denominator of this equation, and it controls for a number of different things in addition to the ETAC or the end-tidal anesthetic dose. And what they did is they used this equation to look at who was sensitive versus insensitive to anesthetics with this more complex equation. And they found an odds ratio of about 2. There was a 2-fold increased risk of delirium in people that had, as measured by this equation, low sensitivity to volatile anesthetics. And this equation is measuring the likelihood that the brain goes into a suppressed state or burst suppression in response to anesthetics. So it's basically very similar to the DARS. It's just using a more sophisticated equation. The advantage of the DARS, though, in our view, is that this equation, while beautiful, is difficult to calculate on the back of a towel or something in the OR. You need a calculator, you need a lot of stuff to do this. Whereas the DARS, you can just measure in the OR on the back of a napkin or a towel or anything. And they both, have a 2 to 4-fold increased odds of delirium if somebody has either low sensitivity or, high sensitivity to volatile anesthetics or low resistance to anesthetics. They're two different ways of saying the same thing. If you have low resistance, it means your brain goes very easily into a suppressed state in response to very little anesthetic. You're not resistant to that change, or you're very sensitive to the effect of the anesthetic that's producing that change. Okay. And I'm going to skip that slide for now, but there's problems with the BIS. And I don't want you to think I'm here as a salesperson for the BIS. I'm not. I've received no money from the company that makes it. And I will tell you, I think we need much better monitors than it. And the data I'm about to show you, I think, substantiates that point. So this is from work we published 4 years ago now. This is Katie Nee, who was a FAER-funded medical student who worked with us, who unfortunately we lost to internal medicine. But I'm sure she's doing great things for the GI patients she's taking care of now that she's finishing her fellowship in that. And this is that study I was telling you about where we had data from about 17,000 patients, 5,000 of whom also had BIS EEG recordings during the case. And I had hypothesized that, I think you guys probably all know that the MAC, one MAC decreases with age, or MAC in general decreases with age by about 6% per decade. Right, so 1.2% isoflurane is 1 MAC for a 20-year-old, but that's not 1 MAC for a 90-year-old. It's a lot more than 1 MAC for a 90-year-old. And my observation as a resident, at least at my institution, was that it seemed that folks might be reducing anesthetic dosage a little bit in older adults, but not by as much as they should be. And so if you age adjust the MAC fraction using that equation, that's the 6% per decade adjustment, then what that would mean is that patients are actually getting a higher dose of anesthetic with age. That was my hypothesis. It turned out that hypothesis was correct. We showed that here, and you can see in the blue dashed line that the average person who was 30 was getting maybe 0.8, 0.85 MAC, and the average person who was about 80 was getting more than 1 MAC. So there is this age-dependent actual increase in clinical practice and how much anesthetic people were giving. Now, a group in Seattle at University of Washington, Will Van Cleve and Alec Rook and colleagues, found something very similar in their data from the University of Washington. So this isn't just at one institution, it's on both sides of the United States at least. It suggests to us this is a national trend, that older patients are getting a relatively higher anesthetic dose than younger patients. Okay, so they're getting more anesthetic. So what does that mean? Well, it seemed to me, at least in simplistic terms, that if you give more anesthetic, that you want to suppress the brain more, and the BIS number should go down. And we looked at what happened to the BIS number, and actually the opposite happened. And this was very perplexing to us. Despite the fact that the older patients were getting more gas, more MAC fraction, they actually had higher BIS numbers. This is a paradox of age, that the BIS values rise with age despite higher AA MAC fractions. And just to show you a little bit differently, a way of portraying that same data, if you graph patients where each patient is, one dot, let's say, and you look at each patient as having a mean age-adjusted MAC fraction and a mean BIS number during the case, and then you group those patients by age, what you see is, in general, as you increase MAC, the BIS number goes down a little bit. That's good. That's what we'd all expect. However, that happens differentially by age. So these are the 30 to 49-year-olds in red here, okay? So as you give them more anesthetic, their BIS number, as you give them more anesthetic on the x-axis, then you see their BIS number decline on the y-axis, right? The line is in that direction. But in people 50 to 70, the same thing happens, but it's shifted up. And in people over the age of 70, it's shifted up even further, and you see no overlap in the clinically used range of anesthetics from about 0.6 to 1.2 MAC of anesthetics, which I think is what most people are using. You see no overlap between the 70 and 30-year-olds. And there's, if anything, about a 4-point difference in BIS values, that they're sort of artificially inflated, if you will, in the older adults. So this made us think we needed something better than the DARS and better than a BIS-based metric. We needed some new ways to study anesthetic-adjusted brain resistance. And I'm just going to tell you about a little bit of the ongoing work we have going on now, where we're looking at what we call frontoparietal alpha power. So this is alpha power over both the frontal part of the brain and the parietal lobe, and it's dose adjusted. So we've got frontoparietal alpha power up here, and we've got 2.5 minus the age-adjusted MAC fraction in the denominator. And we're using a complicated equation here that's for phase lag index. I'll skip over what that means for now. And that's in this equation here for phase lag index of the alpha power. Similar equation. And just to briefly go over this, when you look at, for example, an Alzheimer's disease biomarker pattern in the spinal fluid of these patients, which we've done, and you look at people that have a high ratio of p-tau to A-beta. So without going into too much detail about Alzheimer's, this is a pattern that you see in folks who are more likely to have Alzheimer's. They have, so these are the folks with the high ratio. They have much lower dose-adjusted frontoparietal alpha phase lag index. I know it's a mouthful. And then people with a normal level of this p-tau ratio, who wouldn't have an Alzheimer's pattern, they have higher levels of this power. So this suggests to us that we can use EEG data of how the brain is responding to anesthetics based on the dose of the inhaled anesthetic to at least potentially predict, or at least say that that's associated with somebody's risk of getting Alzheimer's disease, or more accurately, their likelihood of having Alzheimer's disease pathology. And we've found some brain connectivity changes that also correlate with this altered EEG metric. And I'll just kind of skip over that for now. But just to say that we think we're on the cusp of being able to understand individual differences in brain function and neurodegenerative disease risk based on just understanding how the brain responds to anesthetics. So the metaphor I like to use for this is, and the reason I'm using this metaphor is many of you have probably heard of somebody saying, oh, well, anesthesia and surgery is a stress test for the aging brain. And if the person gets delirious afterwards, it's not the anesthesia's fault. It just meant their brain failed the stress test, right? A lot of people have made that point or made that argument. But if you look at it in the following way, I think we need to carry the analogy further. So when somebody gets a cardiac stress test, we don't just put them on a treadmill, let them finish it, and then wait and see if they have a heart attack later. That would be malpractice very clearly. We monitor the heart in real time electrically during the stress test. We look for ST changes. Then they might even get an echocardiogram. And then we refer them for further workup and treatment, or the cardiologists do at least. And they might have a CABG, they might get medical management, et cetera, for coronary disease. But we actually use the information from the stress test to direct further workup and treatment is the fundamental point. Well, now if we think about anesthesia and surgery as a brain stress test, well, we can monitor the brain electrically during anesthesia, just like you can monitor the heart electrically during a physical stress test. And we can see EEG abnormalities in some of these patients. And I've spent a lot of time today telling you guys about these, about burst suppression, about low amplitude alpha power. We know that those predict a risk of neurocognitive decline, dysfunction, baseline cognitive dysfunction before surgery, as well as delirium risk, as well as even potentially Alzheimer's risk. And so the hope is that in the future, we can go from just not even monitoring the brain or monitoring it and just thinking that we're using that to adjust the anesthetic, to also using this data to refer patients for further workup or treatment for other brain illnesses, which could be delirium or could even be neurodegenerative disease in the future. So I'd like to close this part of the talk just by saying I've told you to summarize that EEG alpha power correlates with baseline cognitive function, and that correlates with delirium risk. The brain's resistance or sensitivity to anesthetic-induced EEG patterns is independently associated with delirium risk in multivariable models after controlling for confounders. And understanding the basis of low brain resistance to anesthetic-induced EEG patterns could allow us to use anesthesia as a real stress test for the aging brain, as a stress test that allows us to refer patients for further workup and treatment. Okay, now I'm going to switch gears and go into the next part of the talk. So this is that diagram I showed you at the beginning of this talk about the different techniques for studying brain function in humans. And in this part of the talk, we're going to focus on the cognitive and delirium testing data, as well as, CSF and plasma biomarkers, which are, at an angstrom, very small molecular level. And so we've done a number of studies in my group now that involve all these multimodal measurements, cognitive testing, CSF and blood samples, different anesthetics, functional MRI, EEG, et cetera. But let's simplify this a little bit. And now I'm going to tell you about the work just using the delirium testing, the cognitive screening, and the blood and CSF. And this is work that has been led by Dr. Mike Deviney in our group, who I've had the great privilege to mentor over the last 5 years or so. And he's just doing incredible things with these data. So these are the data we're going to use: the blood and CSF, the delirium data, and the cognitive data. And here's the entry criteria for these two studies. They were both prospective cohort studies, no randomization per se. And they both enrolled folks over age 60, having a good-sized surgery, more than 2 hours, that was non-neurologic and non-cardiac surgery. And they had to be English speakers. We did not enroll any pregnant patients, any prisoners, anybody using anticoagulants, because we wanted to do LPs. So no anticoagulants that would interfere with LPs per the ASRA guidelines, and nobody with severe claustrophobia, because we wanted to do MRI scans. If you're interested, there's the references there. We had a methods paper in JAGS back in 2019, and the MADCO PC main study findings were published in the Annals of Clinical and Translational Neurology last year. But Mike was interested, or Dr. Deviney was interested in a different question using the same data set from both studies, which is what's happening to blood-brain barrier function in these disorders, these perioperative neurocognitive disorders. So this is just a schematic of the blood-brain barrier. And you have a blood vessel here. You have endothelial cells lining the blood vessel. You have astrocytes and pericytes that help make up that barrier on the other side of the vessel. You have smooth muscle around the vessel, which contracts or relaxes, and that's the basis of neurovascular coupling, which we take advantage of in neuroanesthesia. And then you have the brain here, just depicted simply in purplish blue on the other side of this barrier. And the question is, what's happening to this barrier after surgery, and what does that have to do with delirium? We're certainly not the first to study this. There's a number of small pilot studies with 10, 20, 30 patients that have suggested there might be blood-brain barrier dysfunction in patients with delirium, but we wanted to really get a better handle on that in a much larger cohort here. So the metric we're studying here is what we call CPAR, or the CSF to plasma albumin ratio. So as you guys probably know, albumin is a pretty abundant serum protein, and it's much less abundant in the spinal fluid. And so you can measure this ratio, and you usually get a pretty small, low number, and that means your blood-brain barrier is intact. However, if the barrier weakens, then a lot of that plasma albumin will leak into the brain and leak into the spinal fluid, and then the ratio will increase, okay? So this CSF to plasma albumin ratio can be interpreted as an index of blood-brain barrier function. And so we had 316 patients on whom we had post-op delirium assessments. We had about 30 some in whom we couldn't get baseline CSF, or we didn't get plasma, or we couldn't measure plasma albumin. So we still had about 280 folks that we could measure this ratio in before surgery. Then we excluded patients who received albumin in the OR, because that would obviously confound the ratio. And then we had some in which CSF or plasma couldn't be measured at 24 hours. So we had about 207 patients who also had 24-hour CSF and plasma samples that we could use to measure this ratio at 24 hours. And here's what the cohort looked like overall. We had 26 patients with delirium out of 207. And it might seem like a low rate, but remember, these are non-cardiac surgery. Rates are higher after cardiac surgery. And it's a pretty typical cohort for a delirium study, in that the baseline cognitive Z-score was lower in the patients with delirium than those without delirium, and their MMSE scores were also lower. And that matches what we've seen in numerous studies by numerous investigators all over the world, that patients with delirium usually have a little bit of cognitive dysfunction before surgery. These were the surgery type distribution of the patients, and that didn't really majorly differ between the delirious versus non-delirious patients. So what happens to this ratio after surgery? Well, it increases slightly in everybody, and this is different than zero on its own. But then when you look at the patients with delirium, they have a greater shift in the CSF to plasma albumin ratio from before to 24 hours after surgery. And that was highly significant. P is 0.003. And then if you do a multivariable model and you look at the pre to postoperative change in the CSF to plasma albumin ratio, or CPAR, it's significantly associated with delirium risk with an odds ratio of 1.3. So to interpret this, what that means is that for every 1 point increase in CPAR, or the CSF to plasma albumin ratio, for every 1 point that goes up, there's effectively a 30% increased chance of delirium. And there's a fairly wide range, as I'll show you in a little bit, for the CPAR. It can go up multiple points. So it's more than just a 30% risk. For example, if somebody's CPAR goes up by 3, then that's actually a 90% increase in their delirium risk. The other interesting thing here is baseline cognition is also predictive of delirium risk. So this means that the higher that somebody's baseline cognitive function was, the lower their delirium risk is, or vice versa. The lower they were on baseline cognition, the higher their postoperative delirium risk it was. And the interesting thing is the CPAR change is an independent predictor of delirium even after adjusting for this. So it means that postoperative CPAR change is not just a biomarker for folks who were cognitively impaired before surgery. It's actually an additional hit or an additional additive factor related or associated with postoperative delirium risk. And this just demonstrates that point again. So here we've got the pre to post-op change in the CSF to plasma albumin ratio on the x-axis. So a positive number on the x-axis means the patient's CSF to plasma albumin ratio went up after surgery, meaning that their blood-brain barrier became more leaky after surgery. And then we have the delirium probability on the y-axis. And you can see all three of these color dashed or solid lines basically go up as you go to the right. So the more your CSF to plasma albumin ratio increases, the more your probability of delirium is. What's interesting is if you separate the patients out into these different color groups, into those who had cognitive function about 1 standard deviation below normal versus those who had normal cognition versus those who had preoperative cognitive dysfunction, whose preoperative cognitive function was 1 standard deviation below normal, then you see this additive effect, independent additive effects. So you get an increased delirium risk from an increase in this ratio, and that increase due to the ratio is even more pronounced in somebody who already had some cognitive impairment before surgery. In other words, in somebody who was already vulnerable to developing delirium. Next, we wanted to look at whether this was also a predictor of increased hospital length of stay. And our rationale was that, if this biomarker going up, this CSF to plasma albumin ratio, if that's related to delirium, and we already know that delirium from numerous other studies is associated with increased hospital length of stay, then maybe this biomarker would also be associated with increased hospital length of stay. And indeed, that was correct. It is. So for every 1 point increase in your CPAR, you have a 20% or 18% longer hospital length of stay. And then interestingly, this is also independent of baseline cognition, which has the opposite effect. So the higher your baseline cognition is, it's per SD decrease. So for every 1 standard deviation decrease in baseline cognition that you also have an increased odds of staying in the hospital longer after surgery. I'm not showing it here, but the other interesting thing is this actually held true, both of these relationships, even if you added delirium to the model. So that's a little interesting and was unexpected. That means that an increase in blood-brain barrier permeability, as measured by this pre to post-op CSF to plasma albumin ratio change, has an effect on delirium. It has an effect on hospital length of stay, but its effect on hospital length of stay is at least partly independent of it causing delirium, which we weren't expecting. That means it's doing something else to increase hospital length of stay or leading to hospital length of stay increasing beyond causing delirium. And let me show you in a similar graph how we visualize that. So here's the CSF to plasma albumin ratio change from before to 24 hours after surgery. So again, an increase on the x-axis means that somebody's blood-brain barrier is opening and their CSF to plasma albumin ratio is increasing after surgery. And this is the predicted hospital length of stay afterwards. And you see that in both colors, you have a line that goes up as it goes to the right. The more your ratio goes up, the more your barrier gets leaky, the longer you are to stay in the hospital. That's true if you don't have delirium. It's even more true if you do have delirium. So there's an additive effect of delirium as well as change in this ratio on hospital length of stay after surgery. And I'd just like to make one final point in this portion of the talk. This actually has an implication for a lot of biomarker studies in the cognitive dysfunction and delirium field. So there's been a lot of studies that have shown that plasma biomarkers of neurodegenerative disease go up after surgery or go up in patients who have delirium, and that's often meant or interpreted by authors and folks to mean that somehow an acceleration of neurodegenerative disease is causing delirium, or that neurodegenerative disease pathology is somehow involved in delirium, and there's a link between delirium and Alzheimer's disease or something like that. I think our data suggests that it's a little more complicated than that. And so this is a paper by Jennifer David and Leah Acker and Nicolo Tarando's group in collaboration with our group here at Duke. And what we did is we looked at this microglial activation biomarker, YKL40. It's also produced by activated astrocytes. And if you look at what happens to the CSF levels of this glial activation marker from before to after surgery, there's not much change. If anything, there's statistically a very small but statistically significant decrease in this glial activation marker in the spinal fluid. So we would interpret that as meaning, okay, there's not really an increase in glial activation after surgery in the brain. If anything, the amount of glial activation might even decline a little bit, although it's a small effect size. But then what happens if you look in peripheral plasma in these same patients from before to after surgery? Well, wait a second, the opposite happens. The plasma levels of this brain glial biomarker go up after surgery significantly, and that's highly significant. And so what we think is happening here is that this doesn't really reflect an injury to the brain itself. It doesn't reflect increased glial activation in the brain. Because we know there's not increased glial activation in the brain. We measured it right here in the spinal fluid. But I've just told you that there's blood-brain barrier dysfunction 24 hours after surgery. So we think what this means is that you can see at baseline, the plasma levels of this thing, 50 or so here, 50 to 100, are a lot lower than the CSF levels, which are like 150 on average. So what we think is happening is, as the barrier weakens, then the peripheral levels go up because it leaks out of the brain. And then you wind up with values in the same range as what you see here in the CSF, more or less, maybe a little bit that are higher, but basically the same range as what you see in the spinal fluid, suggesting that this biomarker is increasing peripherally, not because it's going up in the brain, but just because the blood-brain barrier is dysfunctional after surgery and more of it is leaking out. And so I think that lends a word of caution or a note of caution to any studies on brain biomarkers in plasma after surgery. They may go up, they may really go up in plasma, and that's a real result. But that doesn't mean they're actually going up in the brain, and that shouldn't be inferred from an increase in the peripheral plasma level. It could just be that they're leaking out of the brain more because the blood-brain barrier is dysfunctional. So I'll just do some conclusions on this part of the talk and then be happy to take some questions. So increases in blood-brain barrier permeability occur in older adults after multiple kinds of non-cardiac, non-intracranial surgery. The people who develop postoperative delirium have even higher pre to post-op increases in blood-brain barrier permeability, and these larger post-op increases in blood-brain barrier permeability are associated with increased hospital length of stay. And finally, I've told you that plasma biomarker changes for brain proteins may actually reflect blood-brain barrier dysfunction rather than brain injury itself. And finally, on a hopeful note, this suggests that drugs or therapies that could protect the blood-brain barrier might actually help lower delirium incidence and reduce postoperative length of stay. So, as Dr. Headland and I were discussing before this talk, delirium is sort of a funny problem. It's not clear whose problem it is. Is it the anesthesiologist's problem to treat it and stuff? Is it the surgeons? Is it the psychiatrists? Is it the geriatricians? Is it internal medicine doctors who sometimes follow these patients on the wards? It's not really clear who this disorder belongs to. And I think part of the reason for that, and part of the reason there's not a lot of implementation of evidence-based guidelines around this to assess patients for it and so on, is that we don't really have a treatment for it. It's where depression was as an illness in the 1960s before the SSRIs came out. Once you have a therapy that can do something about a disorder, then it becomes a lot more important to detect that disorder. And so our hope is that that'll be the direction this field moves in over the next 10 to 20 years, that we'll be able to test drugs and therapies to protect the barrier. We're hopeful some of them will work, and that then we might have a way to actually reduce delirium incidence and post-hospital length of stay. So with that, I'd like to give major thanks to Dr. Mike DeVinny, who I mentioned earlier has been an absolute joy to mentor over the last 5 years. He's a rising star in the field, and I hope you all will be able to have him come sometime and talk to you as well. I'd like to thank all the funding sources that supported this work, all the folks at Duke Anesthesiology, especially my chair, Dr. Joseph Matthew, who's been enormously supportive of this work and my own career development here. I mentioned Mary Kuda-Wright, who's our statistician, all of our surgery collaborators and patients. And finally, I would just like to thank all the folks who've contributed to this work, whether it was by helping us get the grants or edit the grants to fund the work, whether it was by doing all the lumbar punctures or other aspects of the work. These are all those folks listed here. And as you can see, it takes a big team. So with that, thanks very much. And I'm more than happy to take any questions you all might have.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the Anesthesiology Residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.